yes. And do we have any, the acquisitions?
I'm fine with.
We actually had no.
Okay, I was gonna say, we normally do. All right, so what's the next?
I do have one item for consideration, not on the consent agenda. I have a resolution approving and entering into a land sales agreement with Warren County Airport Field LLC relative to parcel number 0813100024 in Turtle Creek Township.
Do we need a motion on that? Do we need a motion on that?
Yeah.
We do need a motion, you looked this way, so I
Yeah, I
didn't know
was
if you
just
wanted me to
gonna-
ask,
yeah,
give any
yeah.
good details.
Yeah,
So this is the item, and Bruce can fill in, I mean, this is the, about a little over 12 acres.
oh, yeah, I'm sorry, I'm caught up now. I read that.
If only I could do 12 acres and it all just sit there and got it, but yeah, this is next to the airport.
Yeah.
and-
So moved.
All right, yes, do you wanna, is that okay?
So we have one add-on.
And then I do have one add-on. I have a resolution accepting resignation of Shauna Jones, Director of Warren County Job and Family Services, Children's Services Division, effective November 1st, 2024.
So we actually need to do that? We need to have a resolution on that?
Just with being a directorship, just sit there and accepting the resignation, so it's effective until November 1st, or effective November 1st.
So moved.
Yes,
And that's all I have.
okay. All right, so today we've got a work session, and who would like to speak about that?
Well, I will,
Nobody wants to speak on it.
Really?
so we're back for our annual, health insurance renewal, for the plan year 2025. We're here with our Partners Hub, Allison and Steve, who comes out annually, so they're gonna give the presentation.
We do have to say, if Steve talks, we have to take it with a grain of salt. He just had surgery for falling off his scooter, so we're not sure the medicines he's on.
Oh, man.
The note to self for everybody, this is like the second or third person, stay off of electric scooters.
Yes, you hear the dangerous, and I can confirm. I'm a statistic.
I feel like he was just telling Susan how he had never broken a bone too, and so he jinxed it completely.
talk about that on the flyer.
I know, right? All right, well, good morning, everyone. Thanks for having us today. As Tammy mentioned, we wanted to talk through just a recap of where we are from a budget standpoint with the healthcare spend, and then talk through some of the strategies and recommendations we have for 2025. So a lot of things on the agenda today. I will breeze through the first few, and I want to get to some of the recommendations that we want to discuss. So really the first thing, briefly, is the historical analysis, kind of how we've ran over the course of the last 10, 11 years. As you can see here, this is going to give you a chart. We bring this chart every year, and we compound it every year with a new set of data. Essentially what this is saying is year over year, the county is performing better than trend. Trend is typically around an 8% year over year increase. Based off of Warren County's average trend, it has increased about 2.5%. So as that compounds every year, you can see obviously the differential there where we are in 2024. Really quickly, recap for 2024. We renewed with United Healthcare and Optum RX. We did make a few plan design changes to that deductible and out-of-pocket maximum. The rates did increase to 4% there, and then we also did that dependent claims audit. I won't go through all of the ancillary items here. Just remember we did renew with Tokyo Marine, and we'll talk through that a little bit further when we talk about stop loss. All right, getting into some of the meat of what we want to discuss today. There's essentially three different focus areas we want to pinpoint in our conversation today. Essentially, where is the cost rising and how are we going to combat that? First thing is stop loss coverage. That's a big priority we want to talk about. We do not have proposals to share today, and we'll talk through that a little bit later on as to why. But one of the main reasons you can see on the page here is the stop loss ratio is a little higher than we would want it, right? About a 450% loss ratio, meaning how much we're paying in premium compared to the stop loss reimbursements that Tokyo Marine is paying.
And that's even with the claimant that we had lasered off.
Yeah, so you had an 850,000 laser liability in 2023. When we came last year, Tokyo Marine took that laser liability off, which we thought was, are you sure you want to do that? Because we knew that that large claim was going to be ongoing. It's kind of a win-win for you, because if you did not take that laser liability off, you would be on the hook for that $850,000.
But now, because it's in this, the rates are gonna go up, and there may
Correct.
not even be somebody who wants to take on the stop loss insurance.
Correct. So you've had about $1.1 million in stop loss reimbursements through August, and Tammy probably has even more up-to-date data through September for you. That is an ongoing large claimant. They did laser a different claimant for 2024 at $500,000, and year-to-date, that large claimant is at about $170,000. So based off of our clinical notes and, you know, the stop loss, they thought that that laser liability wasn't going to be nearly as much, that the top claimant. And that shows that the stop loss ratio obviously is higher than they'd like it to be. So we'll talk through that a little bit more based off of that data and what we want to do about that. The other area is pharmacy. I know we talked about pharmacy last year as well. Across the board, trend is that pharmacy claims are rising, right? Not necessarily just at the county, but overall we're seeing that across the board. The main reason for that is specialty spend. So those specialty medications, they account for a tiny bit of your membership, but a whole lot of cost, right? So when we look at yours, you know, 4 of your top 10 large claimants are all pharmacy related, and those are specialty drugs. So how do we combat that spend? We want to talk about some recommendations of making sure that obviously there's accessibility for prescriptions for everybody, but how we manage that and make sure that the cost is reduced. And the other thing is just large claimants overall. This is part of the pharmacy spend, but just 1% of your membership accounts for almost 50% of that total spend, right? So that's just showing that it's not necessarily across the board that everybody's hitting their deductibles and it's just an influx of spend. It's those high cost claimants that are driving a lot of those paid claims.
What is the total of our membership?
I'm sorry?
What's the total? When you say 1% of membership, what's our total membership?
So you have about, I would say, 650-ish employees.
We have about 900 covered under the healthcare plan.
Oh, okay. And then membership wise
Our membership, so we have about 2,000 lives, about 900 covered under the healthcare plan, but about 1,000 employees that are eligible.
Yep, okay.
All right, thank you.
Yep. And just for reference too, in July alone, that top claimant had about $650,000 in paid claims. All right, so we'll talk about the proposed budget and then, like I mentioned, talk about those focus areas a little bit more and the recommendations we have. So when we look at your proposed budget, few different charts here if you want to, or the columns on the chart here if you want to put your eyes on those. The 2024 appropriation was about $12.6 million. Actual spend through September is almost to that $12.6 million. Total claims on a monthly basis have averaged around $1.2 million. So when we annualize that, obviously that is going to be above that appropriations for 2024, mainly related to the high cost claimants on the plan. So when we're thinking about 2025 and what that total budget is, Warren County has proposed, it's a range here from $14.1 million to $15.7 million, depending on some of these recommendations that we're going to talk about today. So a few other things and caveats at the bottom there. This gross spend that we're talking about does not take into consideration some of those pharmacy RX rebates that you receive on a quarterly basis. So year to date, that's about $750,000. Just for reference, in 2023, it was $1.3 million. So kind of a credit that comes back to the county for the utilization of those specialty drugs. Essentially, it would be nice to not get any rebates, because if you're not getting any rebates, you're not having any of that specialty drug spend on your plan, but it is nice to have some of that credit come back. We'll also talk about the contributions as well, what we anticipate the increase to those fully insured equivalent rates. The county does propose a 15% increase to those rates overall, and we'll talk about that and how that, the cost share for employees and membership relates to that. All right, so focus area 1 was that stop loss. So this is another chart that we bring every year to talk through overall, where have we been with stop loss and where are we today? So the big thing that we talk about every time we come out is when you added that aggregating specific in 2018, you can see that reduction in overall annual premium. Adding additional liability to the county is going to offset some of that premium cost. So over the course of, the last 6-7 years, your stop loss premium has remained pretty stabilized. Now, we've had some conversations about how to manage that, whether it's increasing the specific deductible, increasing the aggregating specific, those type of conversations, along with the laser liabilities. So as you can see, where we are today, 2024 through August, we are at that 448% loss ratio, with one claim exceeding over that specific. Tammy does have more updated numbers, real time on a weekly basis, and we do have a couple more high cost claimants that are tipping over that specific deductible. So just something to keep into consideration. We have already hit that aggregating specific. So if there are other large claimants hitting the specific, ultimately that's going to be additional reimbursements to the county. The goal of our stop loss, recommendation and strategy is always to go to the market and see what we can do from leveraging competitive data, right? So the last few years, due to where your premium is, a lot of those stop loss carriers cannot beat where your premium is. And now this time, they see where your stop loss ratio is, and they're like, I don't know if we're going to quote. So we did go to 15 different stop loss carriers in the market, all declining to quote today. Now, that being said, we're still pending the Tokyo Marine renewal. Last year when we came out, it was the end of October. It was Halloween, because I remember that. And we did have that renewal. They're waiting to see how data is shaking out in September, and they're looking at their nurses' case notes to determine what that renewal is going to be. So we are waiting for that renewal as it stands today. Another thing with stop loss is it renews January 1st. So we're in October today. We typically like to firm up in October with August or September claims data, just because it's typically how we've always done it. It could be a strategy to understand where that high cost claimant is going to be in the next few weeks, months, if they're going to enroll in the plan in the future, because that can help us with negotiations and leverage that with the stop loss market. So we could ultimately firm up a quote, in November, December, etc. So still pending that renewal. We hope to have that here shortly, and we can share that with you, but wanted to give you just an update in the lay of the land of the stop loss market. Any questions on that? Okay. The other area is pharmacy. The big thing with pharmacy in general is, like we talked about, the claims and the trend is higher than medical. We're seeing the trend for medical be in double digits, around 13, 18% around the market. When we look at your specialty spend in general, it's 6% of the total scripts, but 71% of the total spend. So that's basically saying that only a few specialty drugs are driving majority of that spend. So how do we combat that? One recommendation we wanted to bring to you all is the idea of ArrowRx. This is a drug pharmacy solution in the market that ultimately still provides access to medications to all your membership. But what it's going to do is it's going to leverage the manufacturer assistance programs to let those members who take specialty drugs take them at no cost and have a concierge service to help them navigate how they directly work with the manufacturers to get those prescriptions for free. So it's kind of a win-win for those membership where they're no longer having this drug applied to their deductible through the county, and they're actually getting it directly from the manufacturers, no cost to the county, and then no cost to the member. There is a shared savings component with ArrowRx for the fees concept of it. But ultimately, when we do the analysis of getting some of that specialty drug off of your plan, the projected year one savings ranges from 1.6 million to almost $2 million in year one. We have a lot of different employers, municipalities, clients taking advantage of this today. And ultimately, we've seen about a 35% to 40% savings in specialty drug or RX drug overall in year one. So we do see that it actually works. The other area, not necessarily just using manufacturer assistance, but some of those other higher cost drugs, what they do to reduce the cost is they use a method of international sourcing. When I say international, it's not necessarily all over the world, but through up in Canada is where they source those drugs. The ingredients to the medications are exactly the same. If people have used mail order in the past, it's essentially the same concept where those drugs are being, directly mailed to their front doorstep, refrigerated in a cooler pack, and then it's ready to go. So an idea is certainly to help with the overall specialty spend. It is something that we're going to continue to see rise year over year. A lot of these specialty drugs, it's something that people have to take for the rest of their lives, right? And so if they remain on your plan, we're going to see that constantly hit the plan.
Was there a reason why we wouldn't do this recommendation?
I would say overall, ultimately, immediate savings is one of the main reasons to do it. The only other consideration there, looking member disruption wise, they're going to have 2 ID cards, right? So they're no longer going to have just the United Healthcare card that has Optum integrated. It's going to be a whole new pharmacy benefit manager who would be managing your pharmacy plan. We did look at your contract right now with Optum because you are in a multi-year agreement. There's no termination fees, no early penalties, anything like that we need to consider, which makes it even easier to make that move. The only other thing too, from a sourcing perspective, the state of Florida has done this entirely. They've moved the whole idea of AeroRx. So it's something that we see more municipalities, government entities, and employers doing. However, we're still working from an FDA perspective. They're still, discussing those things too of where this is ultimately going to go. But we had a lot of different employers, municipalities move to this. I know Tammy has reached out to a lot of those companies and municipalities as well for references, and ultimately it is going how they expected, and they are seeing savings.
I think one of the things that we just discussed internally as staff was going from that 1 to 2 cards, and there'll be a little bit of an inconvenience early on. I think those that are in that kind of concierge service, from what Tammy and I were able to uncover, there's about a month or so where everybody's just feeling each other out and making sure everything works. But you get into the sort of that February, March time frame, and it really smooths itself out, and it seems to be working pretty well for those that we've talked to. So I think that we would get out there, we would advertise it as staff. That's one of the reasons we wanted to come early, about a month early to you, or as close to the month, to really get out, educate staff, get out with them and let them know this is coming, and kind of field those questions. But if it really does have the ability to bring some of these savings, and it's the same medicine, a little bit more of a concierge service, yes, there are 2 cards, I think it mitigates to a point where we thought we wanted to make sure we brought this recommendation to you.
I would say it's only typically 2% of the population that's ever gonna even be, not even disrupted, but have to take action, right? Work with Arrow to end up sourcing their drug. Everyone gets their drugs no matter what. It's not like they're not gonna get something that they need. But to Martin's point, that first month or two, somebody's not gonna pay attention to open enrollment or read all the material. They're gonna go try to get their drug, and they're gonna say, wait, why do I have to call Arrow, or what, So that happens a little bit, a few little bumps in the beginning, but it smooths itself out, and then it's a really nice benefit to the employees because they're not paying for that drug if they get it sourced direct from the manufacturer. So it actually saves folks a lot of money. They have that concierge piece to it, so they end up really appreciating the program. It's a really good value add that the county's providing them.
Why would the manufacturer provide the drug for free?
They have to from a assistance program, so there's certain thresholds if your household
Steve, won't you
income
come to the mic if you don't mind?
up here.
Yes, please.
Oh.
Just to make sure it captures on you.
Yeah, so there's certain thresholds on household income that if you make under, it's typically like $175,000 for these manufacturer assistance programs. If you make under that, then you can get that drug free from the manufacturer. It's one of those things that most people don't know about. Most people don't want to complete that paperwork. You have to, disclose some financial info. So
This
most
is a
people
program that the manufacturers have agreed to.
Correct.
And why would it have to be implemented through this process? Why wouldn't they just do it without doing that?
Well, so most employees, again, don't know that that's even an option, and they're not going to go and fill out his paperwork and mail it to the prescription. It's going to be a convoluted process. Most people have no idea. So ARRX takes that burden off of them and does it on their behalf to get them those drugs.
What does AROX get out of it?
We pay them.
Yeah, they're the company. So you have a pharmacy. Evo is your pharmacy benefits manager. They're your technical. That's the pharmacy that's filling all the drugs. Arrow is kind of the strategy that bolts on. Arrow is the company that basically understands how to get these drugs in different fashions. They're the ones that hold the employee's hand, provide the concierge service. So that's the bolt-on strategy that's there. We've had groups doing this for probably 4 or 5 years, if not 6 years now. Had great success. The one thing I would share too, though, is in 2, 3, 4 years of the pharmacy, those manufacturers, are they going to finally catch on and be like, all right, we're giving too many free drugs away. We're going to do something and kind of squash these types of maybe, I don't know.
Maybe they could lower their drug costs.
Or that. So I read an article, I'll send it to Martin the other day, that if you look at the average cost, I think it was Humira, here it's like $1,000, but over in Sweden it's like $98, Canada it's $140. It was crazy. That same exact drug, everything is so much more inexpensive everywhere else. So yes, that could also be it. But a lot of clients are like, yeah, let's strike while the iron's hot. The pain is there, prescription costs, just like you all. We've seen a lot of clients facing this, and it's just unaffordable. And they're like, yeah, let's do something like that.
So net, we pay them for the 1% to manage the paperwork for the 1% of our covered lives that have these specialty drugs. And they basically take care of it all, and once that's all done,
Yep.
they're gonna get their drug, and it'll be no cost to them.
Correct. And you remember that they help. There's that shared savings that Allison mentioned.
And you've netted it out based on your experience now, 4 or 5 years working with this company, that even for what we pay them for this concierge service, compared to the cost of the specialty drugs, we're still making up 30-some%
Yep.
on the cost.
They'll take a percent of whatever they get off the plan. So
I
you're not
see.
even paying them unless they're actually doing a good job and people are qualifying. So yeah, we take all that into consideration. There's a lot that goes in the pharmacy. Your rebates will go down because you're filling less really expensive drug that help with these kickbacks and stuff. So that's kind of a good thing. It's either completely get it off the plan. You still will get rebates, though. They do 100% pass through on any rebate that they do get, and they give it to you all. So we've taken all that into consideration.
You won't receive as much rebates because obviously you're not going to have as much specialty spend on your plan, but we have netted out that estimated rebate utilization you have today from that savings. So, yeah.
Again, not to sound flip or anything, we were just, for the amount of savings, for us to sit there and ask our members to carry 2 cards, we thought was worth the effort for making sure. It was a trade-off for when we see these costs continuing to sit there increase. If we want to continue to provide as best as we can for them to find ways to cut costs, a second card we thought was, for most folks, they will not notice a difference. They'll get their script filled as it normally is. It's really that less than 2%, 1% that'll have this service that to help them with their specialty drugs.
Is the second card just used at a pharmacy? Is that where it's used?
Correct. Yep.
All right, thank you.
Yep.
I don't see it as being really any different than if we changed our pharmacy benefit manager. If we changed our pharmacy benefit manager, all that stuff is different. You get a different card. There's that month of transition if you're on a drug. It's the same sort of thing. It's just in the background, there's a separate company processing those drugs.
Correct.
It seems like a good solution till they catch on.
Hopefully that's a few years.
We've looked at a few other recommendations in the past, making tweaks to the expanded preventive drug list, those type of things, and the ultimate savings there certainly is minimal compared to what we're seeing with this change.
And also too, she brings up the preventative medicines. We don't have enough data. We need to really run it out, probably, according to Tammy, about 1 more year But what we're seeing, if you take some of the specialty drugs out, more scripts are being filled in the preventative medicines. And we're starting to see a kind of a plateauing of some of the healthcare spend. We're not probably have an ability to tell you today it's a 1-for-1, and we understand that it's all preventative. We'd like to collect a little bit more information, but that's something I think that you've done a couple of years ago, that, you know, we're having folks take their diabetes medications and take their high cholesterol, and seeing scripts go up in that form or fashion, which I think actually is a good thing.
Which, if I recall, based on the feedback we got from employees when we did our benefits assessment, that preventative drug list was very popular among employees. I mean, that's where they probably got the most satisfaction. I mean, Tammy, am I remembering that correctly?
Absolutely, yes. It was, the preventive was well received, and it's saving huge amounts of our employees out of pocket.
Yeah.
So they can take their medication that they maybe should have been taking all along.
And to be fair, I mean, there is a cost to the county because we are taking a cost share of those medicines. So you're probably looking at, we're taking on about $300-some thousand additional. But as we start to see some of the health medical plateau, and you know, that's a good trade-off. I mean, what we're really looking at is, and again, I'm just using diabetes, and there's other medicine, but if you're taking your diabetic medications and you're not having that emergency room visit or other types of items, it is helping in the long run. I think it's anecdotal now, and we hope to bear it out as more data comes through.
Definitely. And if we made a move to the, you know, Eva as the pharmacy benefit manager with ArrowRx, they can keep some of those programs you have today. So the expanded preventive drug list, there could be no changes with that. We could grandfather that in with the new PBM. We can also work on, you know, some of those preventive drug lists could be sourced elsewhere. So saving you all money, we could give the members an opportunity to just have those for free if they source them compared to get them domestically. So we can have those conversations too. Right. The other area is just overall large claim spend. So when we look at, and we talked about this as well, that top 1% of membership is driving almost 50% of total spend, right? So how do we combat that and make sure that those members with those claims have really good coverage in place, but we're helping them, you know, maybe that's not necessarily through the county's plan or elsewhere. So one other opportunity or option we wanted to bring is a program called the Samaritan Fund. Basically, the gist of this is to provide large claimants free healthcare, right? So whether it's through a government-sponsored program such as Medicaid or through the marketplace exchange, what this does obviously is removes that high cost off of the county plan. This is completely voluntary. How the Samaritan Fund works is those members, and it has to be open to any member, right? Not necessarily just targeted to certain individuals. Any member on your plan can apply for this program. And what they do is they fill out an application, and then Samaritan Fund will vet through those applicants and see if anybody qualifies for the program. They do work with employers and municipalities, so their clients, to determine, you know, anybody who is eligible, does that make a good fit? Does that make sense for that member to take advantage of the program? If they do get accepted, they work with a coordinator that manages and basically leads them through the path of looking for alternate care and coverage. So whether that is through the exchange, whether it's Medicaid, etc., to give them opportunity for different coverage that makes sense for them, right? We're not going to give them a plan that might not necessarily work for them, or their providers aren't in network or things like that. We want to make sure it's a comprehensive plan for those members. And ultimately, it's completely free for them. So the burden of, if somebody is a high cost claimant, they're dealing with maybe, you know, premiums they pay for their health care, then they're dealing with deductible, out-of-pocket maximums, just the burden of going through any traumatic experience or procedure. So this plan is free for the members, and they do not have to worry about the healthcare costs. So essentially how it works is somebody does get approved, the county does pay a lump sum to the Samaritan Fund to help offset some of those costs. If an employee is eligible, it's $55,000, and then a dependent is $15,000. It's a lump sum, and then that's all that the county would pay for that. The big thing with the Samaritan Fund is it is a national program, and so there are specific deadlines in place. So we are approaching those deadlines pretty quickly, so that's another reason we wanted to come to you all early this year. Essentially, Samaritan Fund needs by the end of this month applicants, so any employee who's interested in this program would need to apply this month in order to qualify. So it's something pretty seamless to implement, and it's just kind of a win-win for your membership. If it works for them, great, and they have access to free healthcare. If it doesn't, it doesn't, but it's an opportunity for them to access coverage elsewhere. Any questions?
Meaning they
on that?
don't have a deductible?
So they would have a deductible, but it's basically paid through the Samaritan Fund. So on a marketplace plan, for example, maybe the deductible might be the same as it is on the county plan, maybe a little higher, maybe lower, but the Samaritan Fund helps pay and offset that cost.
And so is it income, I mean, Medicaid would be income eligible. I hope we don't have any employees that are working here full-time and eligible for Medicaid. I'd like to know if we do. But I'm just trying to think if they're not in the buy-up plan, the only out-of-pocket costs they have right now would be their deductible and pharmacy was,
So pharmacy is included in your deductible and out-of-pocket maximum. It's all integrated together, but they do have that out-of-pocket maximum cost, right, on the base plan. So depending if they're on single coverage or family coverage, obviously that matters. And then, you know, a Medicaid conversation, it's not necessarily from an income base, certainly, but then if somebody is disabled for some reason, or depending on that condition, they could be eligible for Medicaid, Medicare early, those type of things too. And the Samaritan Fund, the coordinators would help them navigate that to see, are there any other programs that you could be eligible for, CHIP, for example, those type of things, or is it a marketplace plan we're gonna engage with? And it's completely voluntary, right? So if somebody's not interested, there's no, you know, we aren't making anybody sign up for this or apply. Ultimately, we want to make sure they have robust, comprehensive coverage, whether it's through the county or elsewhere, giving them that avenue to look.
Well, why wouldn't they apply?
Sometimes I think it's like too good to be true,
Yeah.
you know? So just, it does seem too good to be true sometimes, where it's like, oh my gosh, like free medical coverage, somebody's gonna hold my hand and get me through this. They may just say, you know what, I feel more comfortable with Warren County's plan. It's worked for me for however many years, even though I have all these large medical bills. So we've rolled this out at a decent amount of clients, and you know, they'll typically get like 2 or 3 folks to do it a year. So other people could apply, like in my situation, if I applied and I'm like, hey, I need surgery on my hand, they're gonna say that's kind of a one-off blip on your radar. Not that it's not gonna cost me a decent amount of money, but they're like, this program isn't meant for you. It's truly meant for those with crushing medical bills that just overwhelm, right? So it's kind of like a little bit of a gift.
so we pay if they qualify.
Correct. You don't pay anything. So you might roll it out. We had one group roll it out. They did it kind of late, and nobody just gravitated towards it. And so we'll try it again next year. Now that we've kind of, you know, people have seen it at least once. So they didn't get anybody, so they didn't have to pay anything. We've had several get like 4 or 5 folks on it. So it's going to change those folks' lives for a year. You know, they qualify, they get it for 12 months. The following year, they have to re-up again. So it's not like they just continue to get it no matter what, because their condition may change, right? They may not have some crazy medical things forthcoming in the next year. So they may not qualify the next year. So it is a really nice program. We've jokingly called it like the Good Samaritan Fund, because it really, truly can do a lot for some individuals.
So we'd have to market this to employees like now.
Yeah, to Allison's point, that's one of the reasons here is that we would work to get an email and a blast, and then we'd follow up to get that out by the end of this week. And we're also, and that was one of the things that we talked with relative to legal counsel, just making sure that we're following that it is a blast to everybody. There's no, there is no going to folks that are high-cost claimants, just making sure that everybody's open, has the availability to look at this. They apply, if they so choose to apply, it gets evaluated, and then they make the decision on a completely voluntary basis. And to Steve's point is we're hopeful that we get 1 or 2, and again, we're just looking at how do we, on the specialty spend and on the high-cost claimant spend is, you know, are there individuals that this would be really advantageous to, that we can provide the coverage and the things that they need, but through a little bit of a different alternative, which then also too might change the stop-loss conversation, depending on if people do or don't take advantage of the Samaritan Fund.
Definitely.
And people complete like a PHI form before they ever engage, so they have all that buttoned up with HIPAA and all that kind of stuff too. So the employees have to complete that. It doesn't mean if they complete that, you have to engage, and they could just explore it, and then at the end they could say, you know what, yep, I don't want to, or wow, this is great, let's go for it. So it doesn't commit them to anything, just to complete that and do the evaluation within a concierge individual.
Okay. So getting into some of the other items we wanted to talk about today, obviously those were the three main focus areas. The other area is just the overall contribution share. So as I mentioned earlier, what the county has proposed is a 15% increase to the fully insured equivalent. So essentially what that is the county and the employees portion of the overall rates. This chart here, there's a lot of numbers on here, but essentially what this is showing is if we kept that contribution strategy and that cost percentage split the same as it is today with that 15% increase. So essentially everyone on the buy-up plan pays 15% of that total cost, and then on the base plan, they would keep that cost free, 0% cost share for the members. So you can see here, I put, kind of circled what that new employee monthly rate would be. That is a change there of about $13 monthly for single, and then about $40 monthly for family. We do have a couple other scenarios in the appendix as well if we did want to make any changes to that, potentially, you know, adding a cost shift or a cost share to the base plan. That is something that we've talked about in the past. What makes the county very special from a benefits perspective is that you've been able to keep this base plan at a 0% cost share. So I know that that is something that we've been trying to keep a hold of, but certainly there are scenarios there if we want to look at that further.
So what was our increase last year
4%.
and the year before that?
It was 4% to your fully insured equivalents last year. You know what the county's?
Oh, the year prior, I am not quite sure, I'm thinking
Looks like
of,
it's 7, but I might make that up too.
yeah, I think you're right.
I mean, I guess I'm just trying to, so I hear what is a possibility is to talk about, is there an employee cost share? It seems to me that if our costs increased 4% last year, 7% the year before, or something less than that, less than 7% the year before that, when you're getting into a 15% increase, that's an appropriate time to start talking about cost sharing. You know, I guess what I would say is with these other strategies, you know, maybe going one more year, but, you know, I certainly would be open to some sort of cost share strategy, not necessarily for 25, but we can't sustain a 15% increase, year over year. And I don't, you know, my bias is always in, you know, I want employees to have access to the medical care that they need, whether it's pharmaceutical drugs or hospitalization or whatever, and we do what we can to mitigate that. But by the same token, that's an unrealistic expectation that the county can assume 15% increases year over year and not ask the employee to do what every other county, state, city does, and private sector employees to pay a piece of their own insurance. Just
Shannon, I do have that number, I don't have the percentage, but from 22 to 23, a family buy-up plan went from $1224.72 a month to $1469.36.
On the buy-up.
That's on the buy-up, that's a family.
Yeah, I'm talking about in the base plan.
On the base, the base plan in 2022 was $1327.06 to $1592.19. So from 22 to 23. So that percentage, whatever percentage the buy-up plan rose on all tiers, so did the base plan. So that total percentage was applied to both plans.
But that applies to the departments, doesn't apply to the individual.
Right.
Right.
I mean, that's the issue. I guess I would like to see the trend over time and the percentage of that over time. Cause I don't remember a 15% increase.
A few other things we talked about as well is, you know, ultimately, Commissioner, to your point, yes, it might not be sustainable in the future. Evaluating different options, you know, a lot of the clients we work with keep if they have to go through this, if, you know, we don't have a lot left that have completely free healthcare, but you could keep the employee-only coverage still at 0% cost share.
Yeah, and I'm not even necessarily suggesting it for 25.
Right.
But 15% seems like, I don't remember 15%. I could be misremembering, and you can tell me that, but, that's with these other strategies in place too. It just feels like,
I think what we had the discussion would be is like, so for instance, last year it was recommended to the board 7% and the board decided it best to keep it at 4%. That difference, and Tammy may have to correct me, is we probably left about $300 and some or so thousand, my words, off the table because of that 3% difference. Is, you know, if these recommendations that you seem to be in favor in, at least at the moment, do come to bear, if you want to use 25 as that test, I mean, I just don't know, we may have to be one of those scenarios where I'm asking, we just don't know if we're going to be dipping into surpluses again. And I have the surpluses going into ending 24, going into 25 are significantly strong. Anywhere from 51 to 60 some million dollars true carryover. So that gives us the ability to sit there and do that. We do have obligations in that, however. So I think if we want to use 25 as a way to see what some of these strategies bear, know that if they don't bear out the way we are, is Tammy will be asking us to contribute over to her funds throughout the year.
yeah, I guess that's what I am elevating. I understand the dynamic at play here, and I'm wanting to elevate this to be able to say, all the strategy suggestions that you make seem perfectly reasonable to me, and I think they're well thought out and prudent for us to try. The stop loss issue, we won't know for a little while. But I guess I'm just saying, gee, we might be needing to have a different conversation this time next year, and I wanna put everybody on notice at least that, you know, this is not insignificant. How do we keep providing the same level of insurance for employees in a way that is sustainable over time?
Right.
And I think that's part of the communication strategy that myself, Tammy, and Faith, Susan, are gonna sit there and have to have with folks. We did it several years ago. We can bring it out. We to sell the sizzle tour of letting folks know, these are our strategies. These are what we're trying to maintain. Please take advantage of those strategies so that we can bring our overall cost spend down so that we're not in a position, hopefully, to sit there and have to start talking about cost share. But if you're not gonna be participants and consumers, that is something that is potentially very likely. If 15% is not a number, is there a number that, I mean, last year, again, we recommended 7, it went to 4. Is there a number from
Well, it's obviously not enough, because we're gonna be, after September claims, it looks like you're gonna be outside of appropriation. So we have the fourth quarter to get through. that we're gonna have to dip into. So 4% wasn't enough, and now we're gonna be behind the 8 ball. So I don't know, I mean, I'll defer to you all to say, this is what it's gonna cost to make it whole. I don't like having to dip in, you know, outside of an appropriation for an entire quarter. You know, it's one thing if it's in the last month, but yeah, we're gonna have to go 3 months. You know, we're off by 25%. I mean, we did that. I understand it, we did that, but I don't wanna do that again. It's not predictable.
So the cost share, obviously, piece is pushed till a 26 conversation, but the 15% increase is something that you believe is appropriate for, like, the buy-up plan and what departments will bear for those that pick the base plan. That's at least what I'm hearing.
And what's the actual, what does 15% equate to in cash?
Just under $900,000.
So another $1 million.
I think, and Tammy, I don't want to put words in your mouth, I think what we're trying to anticipate and put in the air is we'll see savings based off of these implementations. We'll raise additional revenue, and it'll balance itself out as close as possible is kind of what we were hoping to sit there and do, is if we can do all these things and we get some good implementation, that we'll see this balance act. I don't want to put words in your mouth.
Yeah, especially if we think about even the pharmacy change, if we're estimating a couple $1 million savings there, you know, to your point, I think that's a great strategy of evaluating how those strategies shake out with matured claims data, see some of that pharmacy come off the plan, and then come this time next year, where are we, do we need to reevaluate that?
Okay.
Okay. All right.
I think also we'll see our wellness, we'll see the preventive medication. I think we'll see some changes with that. As you all implemented the wellness incentive program a couple of years ago, it's well received, right, Dave?
Yes.
And so now we have employees that have a primary care physician that didn't in the past. They're going for physicals. So all of those things, those wellness endeavors will also help to, you know, maybe flatten things out at some point.
Certainly.
The
All right.
the day's day of life, we can have the Shannon, extra day of life,
I
the Tom.
don't. No, I'm good, thanks, though.
Lots of days of life.
We tried.
Oh, then I'll go buy that slide. We have that, yeah. All right, so a lot of good discussion on some of those strategies and recommendations. I'm gonna shift gears a little bit on some of the other value programming that we just want to see your opinions on. One of those being a program through United Healthcare. This is a program that we need to, if we don't want it, we need to opt out by pretty much as soon as possible. Essentially, this is something that's replacing their maternity support program. So if you remember last year, we did implement a neonatal resource available specifically for mothers and children in the NICU. Actually had one member utilize this program, and estimated savings there due to the course of care was around $85,000. This is a completely separate program, but basically maternity management support. I would recommend adding it. There's no per employee per month charge. It's essentially a case rate if somebody decides to take advantage of it. So just wanted to get your approval if you wanted to move forward with that.
Yeah, this is the $925 is what it costs us, and it saves the plan. It saved the plan in this one case, $84,000.
That was the neonatal resource.
Oh,
So it's two different programs. This one's for anybody who's going through pregnancy. So essentially pre-pregnancy, going through the process, just an additional resource, 24/7 nurse line, those type of things.
So how do we get into this program?
So basically you will be opted into the program unless you want to be opted out.
Okay,
So
if
that's,
we're opted into the program, how does somebody tap into this?
it's voluntary. So essentially what happens is through typically claims, so I dealt with this last year myself, they see, my first prenatal appointment, and then they reach out to me via, I get a little postcard in the mail if I want to take advantage of this maternity program. Or, you know, if they go on the site and they see stuff, they can call the nurse line, they can engage themselves. It's not, you know, mandatory by any means, just certainly providing a resource to pregnant mothers and their children.
All right.
Yeah. It's typical for fully insured business, it's embedded into the program, but
Yep.
you being self-funded, you have the opportunity to opt out.
Okay, I don't see any reason to opt out.
Yeah. Alrighty. Another area is just due diligence wise, we wanted to look at your health savings accounts administration. Ultimately, a lot of the different banks are going out of the business for HSAs in general. It's not producing revenue for them, profit, and ultimately they just don't want to deal with it. You all are with First National and you have been for quite some time, but we wanted to vet the market. We did look at Chart Snyder. They're the ones who help with your HRA. So they do have a per participant per month fee, and then HSA Bank was another vendor that quoted. Everybody else, like I said, banks were like, we're not doing this anymore, we're not doing it for employers, municipalities, so they did not quote. Ultimately, we would recommend just remaining with First National. The basis there is there's going to be blackout periods, transfer funds, all sorts of things to worry about, but wanted to do the due diligence and see if you had any questions there.
Nope.
You're good? Okay. Good deal. Another area is COBRA. So COBRA administration is something that we're seeing a lot more of our clients outsource rather than do it in-house. Ultimately, right now you do administer your COBRA in-house with a lot of different legislation, compliance concerns, and just the administrative burden. This is something that we might want to consider outsourcing in the future. We did get quotes for this. Chart Snyder and United Healthcare being two. United Healthcare already doing your medical made sense, seamless integration. Their pricing is 55 cents per employee per month, so around $6,000 annually to administer your COBRA. Essentially what that would mean is that any member who leaves the county and gets those COBRA notices or signs up for COBRA, United Healthcare would deal with that, and it would be completely outside the county's control. So it's not like, you know, ex-employees are working with your HR team anymore, anything like that. So we have seen increase in clients handling it this way. I don't know if you had any questions on that.
Is that what you want, Tammy?
I think it's a good idea due to all the compliance, and it's just right now it's a staff of Faith and I, and it is, COBRA is, it's a lot of work, and we have to be so careful with it, because you know, it's a federal thing, and if we mess up, it could, we're always very careful, but you know, it could happen. So, and as we have, you know, as our population changes, employment, it is, it's
happening more frequently. We have more people on COBRA.
Right, yeah, correct.
I don't think I have any clients your size who administers it in-house anymore.
It's better than hiring an FTE to do it.
Alright. Alright, we'll get into some of the other benefits real quickly here. Just one slide quick on this. No market bids to discuss. Essentially just want to talk about those. The dental, you're in a rate guarantee. I know we evaluated that last year in the network as well. Due to some of the changes with the plan design, increasing that out-of-network benefit, we do anticipate an increase to overall claims expenditure in 2025. So that's about 11% increase there. We are seeing that across the board based off of clients and the out-of-network reimbursements we're seeing. A lot of dentists in general, we talked about last year, are going out-of-network with all different insurance carriers, which ultimately adds a different weights to employers and municipalities who self-fund their dental. Vision, you are in a rate guarantee through 2026 with IMED, so we are projecting a 35% decrease to overall claims there. It's about $50,000, which we've seen a decrease in your vision claims actually year over year. Life and disability, so basically you are in a rate guarantee through that as well. there are going to be some enhancements this year during open enrollment where we are going to be able to offer a true open enrollment to all employees. So not necessarily employees who are new hires. Everybody is going to be able to enroll in additional voluntary life insurance if they want to, without having to worry about evidence of insurability or, you know, those medical questionnaires. We did this a handful of years ago and it was a good success. A lot more people enrolled and wanted this benefit. So we're happy we are able to do that again. And then there's just a few other things for the benefit increases of the amount that people are able to enroll in. Any questions on that? All right, so this was just real quickly on the dental plan. So one other consideration when we're thinking about contribution shares, right now on the dental side, you know, employees don't pay anything for their dental insurance, which is an amazing benefit as well. But if we're looking at other cost shift opportunities, one other option is if employees do pay a cost share to that dental due to the increase that we are seeing. So if that were the case and they pay 15%, you can see the employee monthly rates there underneath that January 1, 2025 renewal. Single would be about $5 a month, and then family would be about $12 a month for their dental benefit.
I don't wanna, I guess, get jerked from the commissioner, but seeing what we talked about from the cost share for the other, why don't we hold this pat until maybe 26, and then
Yep.
we have much more clear direction of where we sit.
Yeah, sounds good. And that's all we have.
Okay.
I think we have direction from you all, and we got some emails we gotta get out and some schedule of sell the sizzle tours that we have to get out for, but I think that's what we were looking for, is just direction and how we can try to bring balance to what has got a little off skew with some of these specialty drugs and some of the high cost claims. So,
Definitely.
Thank you.
Thank you, appreciate it.
Thank you.
All right. Is there anything else we need to discuss?
I have nothing else on the agenda unless Bruce or Susan, Crystal, I don't have anything else.
I do not.
There's a gentleman in the public that I mentioned.
Is there, okay.
Oh, my bad, I just, that's fine.
I'm sorry, what?
No, sorry, that was an interim song.
All right, is there anybody
We're good.
else? Thank you so much.
Thank you.
Take care. Anyone else, seeing we've got a lot of audience participation?
Anyone?
There's only one other person in the room, but they're not jumping up. So do I have a motion to adjourn?
So moved.
All right, thank you.